not a very big difference. Another factor is the substance itself. One factor there kind of within that is contamination. So when someone buys something, off the street or on the internet, and it can potentially be containing other drugs or cutting agents they're not aware of, and it's hard to know whether those are harmful, that's an increased risk that is very difficult to know or characterize. Certain drug combinations also increase risk. And then the infant and the parent themselves matter. As with many things, a healthy term infant who makes lots of wet diapers, whose systems of elimination work well, is going to be a lot more resilient to exposure than, say, a preterm infant or an infant with reduced liver function. And the same goes for mom. There's also some genetic factors just related to drug metabolism that come into play, especially with opioids. But again, that's something that we usually don't know ahead of time. Just going to review some key points from the overall recommendations. It's important for healthcare providers to give information and guidance about lactation both before and after birth, including health benefits, as well as information that is specific to the substance use history of the parent. And that doesn't have to be what, they may not be using anything currently, but maybe they use something before pregnancy or in the past, and we want to provide information that addresses that. And then to provide lactation support, which in some cases can look like supporting new moms to express and discard milk if necessary. We also recommend that healthcare providers, again, discuss harm reduction strategies and help patients, kind of create backup plans in case of substance use. And harm reduction in this space looks like taking care of your nutrition needs, finding responsible childcare for times when you're intoxicated, or knowing what to do if an infant does consume a substance and when they need healthcare. Specific to lactation, parents also need information about pumping and storing and discarding milk. Nursing is recommended, as I mentioned earlier, with medications that treat opioid use disorder. Pumping and discarding is not necessary with nicotine or cannabis, although there are some considerations that we'll get to later today. Of course, less or no use of those is preferred. Some opioids and stimulants do require pumping and discarding after use, and those times vary, up to 5 days at the high extreme. Excuse me. Other substances, the need really varies by the specifics of the situation, often the quantity taken. And alcohol, depending on the timing, someone who has a single drink after eating a meal right after feeding may be totally sober by the time the next feed rolls around, and they might not need to pump and discard, although heavier drinking is a different story. Okay. So we'll be talking through 2 different kind of case scenarios today. We have Kara, who is pregnant for the first time and uses methamphetamine about every 6 to 8 weeks since beginning treatment in her earlier in her pregnancy. We also have Blaine, who is in recovery from opioid use disorder, takes buprenorphine, and they also smoke cigarettes. We will come back to them shortly. All right. So medications for opioid use disorder, or MOUDs, which usually that's referring to methadone or buprenorphine, which are kind of the gold standard medications, especially in pregnancy, although we'll talk about naltrexone a little bit too. Every organization that concerns itself with the healthcare of infants and mothers supports breastfeeding while taking one of these medications. And there are really some specific benefits in this situation. A big one is that when these infants are breastfed, they're less likely to need pharmacologic treatment for withdrawal symptoms. There's also, in this population that is really exposed to, can be exposed to very high levels of stress in their lives, the beneficial hormonal effects of lactation are really valuable, like that suppressed stress hormone secretion. But most importantly, in qualitative research, mothers with opioid use disorder who were supported by healthcare providers to breastfeed report that it helped them really build confidence as parents and kind of turn a corner as they take on this new role in their life, that helped them feel close to their babies, especially when they were hospitalized for withdrawal symptoms. And then all of this together kind of galvanized their commitment to recovery. There's also some evidence that rooming in, like as a hospital policy in general, is associated with the higher likelihood of these infants being discharged in their mother's custody and these families staying together. Very small, really trivial quantities of these medications go into milk. In most cases, the amount an infant consumes via milk is quite a lot less than they would be directly prescribed to treat withdrawal symptoms. And really quickly about naltrexone, it's only been studied in one dyad, but showed quite good outcomes. And in any case, it's because it's an opioid antagonist, we wouldn't expect any adverse impacts on the infant, like sedation or anything like that. Some recommendations for working with these patients in particular are, first and foremost, to provide medically accurate information and encouragement that breastfeeding and chest feeding is safe and recommended while taking an MOUD. And additionally, providing lactation care that is really tailored to the patient needs, including information about infant withdrawal, hepatitis C, if that applies to the individual, and so on. We also, because these patients really can face really extreme stigma and even hostility in the healthcare system, we really encourage healthcare providers to seek continuing education to improve their skills and understanding when it comes to substance use disorder. So that can be, specific education, could be motivational interviewing. There's a lot of ways to approach that. Okay, so we're going to talk about Blaine. So Blaine isn't so sure about how they want to feed their infant. They've gotten kind of mixed messages. So maybe we can, I guess maybe we don't have chat abilities. So think to yourself for just a second, or if you are tuning in with a colleague, maybe talk with them. What kind of information would be helpful to provide to Blaine as they sort of decide how they want to feed their baby? One is just regular old, what are some of the health benefits of breastfeeding for her and for the kid? What information can she be given that's specific to buprenorphine? What's specific to tobacco use? Anything specifically about hepatitis C, and then also about infant withdrawal and breastfeeding. Okay, so we're going to go into the rest of opioids and benzodiazepines, which I just have grouped together because they're both central nervous system depressants and have some things in common. So combinations of these drugs, of any depressants that kind of work together synergistically, really raise risks for both parents and infants. And the majority of adverse drug reaction reports for nursing infants that are in the literature are from combined opioids or combined benzodiazepines, or all of those combined. And they also really raise the risk of overdose for the parent. As far as risks to a nursing infant, we kind of can see that the mild end of this would be just an extra sleepy infant, all the way up to apnea on the very severe end. Of course, that's extremely rare, but it has occurred a few times. We see that sedation is much more common for infants exposed to opioids than for those exposed to benzodiazepines, at least in the context of prescribed use. There is evidence that when the parent themselves is sedated or groggy from opioids, that can be kind of a warning sign that the infant may be affected as well. I'd like to focus in a bit more on some of the more commonly used opioids. So heroin is one, and it's metabolized through a couple of steps into morphine, which can really last a while in the body. We estimate that it's safe to resume nursing once the milk concentration falls to about 13 micrograms morphine per liter. If you have, the place you work has lab capacity to test that, that's a really great way to be certain, kind of use that benchmark. Or alternatively, about 3 micrograms per liter plasma in blood plasma is the other threshold you can use. And that should occur in most cases really by 36 hours after use, but in extreme cases, like sort of very high dose and also a slow metabolizer, that could go all the way up to 5 days. On fentanyl, there is limited evidence. It's sort of all very clinical. There's not really evidence on fentanyl more in the context of opioid use disorder. Although the evidence we do have shows that very little fentanyl is transferred into milk. Typical clinical use, say for starting up anesthesia, really doesn't require pumping and discarding at all. It's eliminated quite quickly. There is one case report that was pretty interesting where a mother was taking a 100 microgram per hour transdermal patch. So that adds up to 2.4 milligrams over the course of a day, which is it's quite a lot. In this case report, they tested her milk and it had about 6 micrograms of fentanyl per liter. And after exclusive breastfeeding for about 2 weeks, the infant had no detectable fentanyl at all in their bloodstream and appeared to not be affecting them. So there's a good indication kind of that even with a pretty large and irregular amount of fentanyl being taken in, that it's not affecting an infant. We again have a milk concentration benchmark available here where nursing is okay once those levels fall to about 7 micrograms per liter. If testing isn't available, we recommend a 3 to 5 day waiting period before resuming nursing, which is kind of on the conservative end. Some clinical experts that we've talked to find in practice that it's usually they're usually getting fentanyl cleared by about 2 to 3 days after the last use. With regard to other opioids, especially when they are being used in a clinical setting, the lowest effective dose for the shortest necessary duration is preferred. And if doses above these thresholds in the right column are needed, there's a somewhat higher risk. And in those cases, that parent could, for instance, try avoiding feeding until a few hours after taking that opioid, or doing mixed feeding, or just monitoring the infant really, really closely. Our opioids recommendations here are to monitor the infant for these signs. Signs of opioid toxicity, and also to monitor the birth parent for sedation. Parents should use harm reduction strategies like room sharing, but not bed sharing, getting childcare if they use, and so on. And again, the pump and discard timelines vary up to 5 days at the maximum. Benzodiazepines are in more of a gray area. They do tend to have quite long elimination times that are extended, especially in newborns. We want infants to be monitored here for sedation and also appropriate weight gain. If a parent has been taking benzodiazepines, long-term or quite high doses while breastfeeding, we really want to do either a gradual taper or a gradual weaning to reduce the likelihood of that infant having withdrawal symptoms. And And our recommendations for benzos are pretty similar to opioids. One infant monitoring concern here that is different is neonatal jaundice. Um, and as mentioned earlier, these really should not be combined with other sedatives. Okay, I'm going to move on to stimulants. So again, for a nursing infant, these carry risks that range from an irritable infant that doesn't have quite enough of an appetite all the way up to really severe neurological impacts like seizure. And of course, those severe impacts are more rare if they have occurred. Available evidence indicates that it is safe to nurse 36 hours after using cocaine. Note that if alcohol is consumed at the same time, the body makes a metabolite called cocaethylene that lasts for a longer amount of time, and we don't really have evidence about that. So it's best not to combine those if possible. For methamphetamine, researchers have found that at 48 hours after use, the exposure is really going to be trivially low, and that elimination is totally complete by about 100 hours after use. Interestingly, we actually have some evidence here that methamphetamine, at the point where it becomes undetectable in urine, has already been undetectable in milk for over a day. So if someone does take a urine drug test for this particular substance and is negative, we actually do know that their milk is going to be negative as well. Amphetamine and methylphenidate appear to be safe for nursing infants at prescribed doses. However, of course, if with misuse or with much higher doses, adverse effects are more likely. And our recommendations here are to monitor infants for signs of stimulant toxicity, like you see here. Parents should be especially careful that they're not exposed to via other routes, so via inhaling smoke or direct ingestion. There was a case report of an infant who consumed cocaine directly orally and got very sick. In addition to that, we do want parents to be aware that stimulants, again, that are purchased, not from a pharmacy, they are commonly adulterated with fentanyl and with other substances. So you should be aware and be careful there. Okay, so let's talk about Kara. Kara arrives to the hospital in labor. She last used methamphetamine about 6 weeks ago. She's really excited about breastfeeding. And so the first question is, should you support her? Yes. So Kara should get some encouragement to breastfeed, support from a lactation consultant. It is sort of more important, especially with people who have, potentially a trauma history, to volunteer support rather than kind of waiting for them to ask for it. If that makes sense. And we also want to help Kara have a plan for future use potentially. So I'd like you to maybe, locate a notebook or something to write in, or, talk it out. What are a couple of ways that you could start a conversation with Kara? There's no one right answer here, but, a lot of people just aren't used to talking about substance use. So I want to give you a chance to practice here. And I'll just pause for maybe about 30 seconds. Okay, so again, there's plenty of ways to approach conversations like this, and the main goal is just to be non-judgmental and sort of approach things with an open mind. But here's a few ideas. Before you and your baby go home, I want to make sure that you're totally prepared to keep them safe and healthy. Let's go through this handout about stimulant use and breastfeeding together. Or I saw in your records that you're getting treatment for methamphetamine use in the past. Since that does get into breast milk, I want to talk about what to do if you happen to use in the future. Or finally, seems like nursing is going really well so far. That's awesome. I know you're in recovery from methamphetamine use, and I'd really like to chat about methamphetamine and breastfeeding for a minute. Okay. So you've started this conversation, and we do need to get some information to Kara while in this conversation. So go ahead and think about what she needs to know. One thing she needs to know, just to start off with, is that it's dangerous for babies to be exposed to methamphetamine. Another thing to know is that it's really important for her to use away from her baby to ensure that that infant is not exposed to smoke or fumes or other sources of exposure. She'll need to arrange childcare ahead of time. And she'll also need to plan for her baby's food needs. So that can be sort of pumping up a store in the freezer, that could be purchasing formula, it could be purchasing donor milk. But in any case, that will need to be planned ahead for. And if she does use methamphetamine, she should pump and discard milk for at least 48 hours afterwards. And during that time, she should also pump often enough to maintain her supply. Okay. Next up is nicotine. There's an interesting kind of body of literature here about the actual impacts on milk composition related to tobacco use. And we do see that there are negative impacts on the oxidant-antioxidant balance, as well as on the micronutrient content, especially iodide. There's also increases in heavy metals and then nicotine content as well in milk. But despite all of those impacts, we do see that infants and families with maternal or household smoking who are breastfed have fewer sick visits to the doctor. They're less likely to have colic. They're less likely to have ear infections or negative respiratory outcomes, including incidence, severity, and hospitalization for respiratory infections when compared to formula-fed infants in similar families. In terms of medications and alternatives, bupropion is an option. It seems to lead to very low infant exposure, although there may be risk of seizure that has showed up in 2 case reports of 6-month-old kind of partially breastfed infants. It's not clear if it's attributable to the medication or if it was just kind of a coincidence or what exactly, but that's something for parents to be aware of if they consider that. Nicotine replacement therapy, in addition to being, a treatment for this, is a really powerful harm reduction option because it completely eliminates the risk of smoke, both for parent and child. Vaping is a somewhat weaker harm reduction option. And finally, varenicline, there's no evidence during lactation for that medication, but it's a similar type of molecule and has a similar action as nicotine. So we kind of expect the risks to be similar to NRT, but again, there's just no direct evidence there. So to recap, in the context of nicotine use, breastfeeding is safer than formula feeding. NRT is safer than vaping, which is safer than smoking cigarettes. And any reduction at all in quantity consumed per day is really worth celebrating. Nursing is recommended for nicotine users, and pumping and discarding is not required. That said, we recommend kind of reducing exposure to nicotine via milk to the extent possible. One strategy to kind of achieve that is to only smoke right after nursing. And same story if someone is using like gums or another kind of fast-acting nicotine replacement therapy, only using that right after feeding the baby is a good strategy. There are so many harm reduction opportunities here, all the way from just reducing nicotine intake to reducing exposure to environmental tobacco smoke, to supporting the lactating parent's nutritional status. And finally, SIDS is, as I'm sure you're aware, really heightens the risk. The risk of SIDS is really heightened when parents smoke, and that risk is higher when bed sharing is going on, but it's higher even than that when the infant sleeps in a separate room. So room sharing without bed sharing is particularly important for these families. All right, so let's go back to Blaine. So you talked with Blaine about some of the health benefits potentially of starting up breastfeeding, and they decide that that's what they want to do. There are many harm reduction opportunities in this situation, so I'd like you to turn to a neighbor, turn to a notebook, whatever works, and just write down as many as you can in the next 30 seconds or so. Okay. That's some options here. I think some things that I haven't mentioned specifically would be like taking a prenatal vitamin containing iodide, or getting a HEPA filter and using it in the home to try to kind of clean up the air and reduce smoke exposure. Next up is cannabis. So cannabis tends to be used postpartum by moms who are less privileged and more often exposed to violence and stressful life events. This isn't the case for everyone, but many people, and especially in this time period, use cannabis kind of attempting to self-manage mental health symptoms, physical pain, GI symptoms. And there seems to be sort of a thought going on that because it's like natural, it's a safer alternative to medications, which isn't, or we don't know if it is true. There's no evidence of acutely harmful impacts on infants like we see with some of their drugs. However, there may be subtle, longer-term impacts on development. These are really understudied. There's some evidence that with prenatal exposure, there can be impacts on memory and attention, with really heavy, like daily or more than daily prenatal use. And those impacts start to emerge when kids are around 3 to 4 years of age. And we just don't have evidence on that age group for postnatal exposure. And again, exposure via milk is much lower than it is in utero. So it's not clear that those are very likely to occur. We really just don't know with the evidence that's available right now. On the good news, infant exposure to THC via milk is very, very small compared to what the lactating parent consumes. In the literature, we see a huge range of THC concentrations in milk, and the really extreme high was one mom who was smoking 7 times a day, which is very heavy use. And her infant was estimated to be taking in about 52 micrograms THC per kilogram body weight each day. We can kind of compare that to a more typical adult recreational dose, which would be around 140 micrograms per kilogram body weight. So that's a lot. But even in this infant was healthy and developing normally at 8 months per their pediatrician. In the case of cannabis use, we recommend promoting lactation while encouraging parents to discontinue or at least reduce their use. As with tobacco, we recommend spacing cannabis smoking as far from feeding as possible. And in particular, trying to avoid feeding around 1 hour after smoking when the concentrations are highest. Okay, finally, alcohol. So ethanol is a very small molecule. It passes very freely between milk and the bloodstream. So when someone is sober and their blood alcohol content is 0, their milk alcohol content will also be 0. And the impacts of alcohol, on a nursing infant vary just by how much is consumed, of course. With light drinking, we do see that there's some impacts on lactation where probably related to letdown, that less milk is produced in the next feeding compared to when the same parents are sober. Infants then tend to be fussier, have shorter sleep episodes, and have somewhat less coordinated dietic interactions, but these are all really mild impacts. There are some case reports of various GI complaints for infants exposed to alcohol via milk. And then with heavier alcohol use and exposure, sedation is a concern. The evidence on kind of long-term, more developmental impacts is very mixed. And that's partly because people who drink postpartum are different from those who don't. They tend to be older, wealthier, better educated, sort of generally more privileged. So there's probably some aspects of the caregiving environment that aren't controlled for that are muddying these waters a little bit. There do appear to be impacts on academic outcomes that wash out in time. And there's evidence that postpartum drinking can worsen fetal alcohol spectrum disorder. As far as medications go, there's no evidence during lactation on acamprosate, disulfiram, or nalmefene, but naltrexone is an option. We talked about that a little bit with MOUDs. And as with opioid use disorder, breastfeeding and lactation can play kind of a supporting role in recovery from problem alcohol use and in developing that caregiving role. Ideally, lactating mothers pump and also eat a meal before drinking. Those two both reduce alcohol absorption. We recommend waiting to nurse until the parent is totally sober. I understand there's some debate as to the accuracy of milk test strips. However, any tool that measures blood alcohol content is adequate or can just do a standard waiting time. And that just depends on how much is consumed and weight. So 180-pound person consumes 2 standard drinks. We just need to wait 4 total hours before they're completely sober. Okay, so in conclusion, I want to encourage you to center the birth parent in infant feeding, to empower parents with information so that they can kind of go out into the world and make the best decisions possible for their families. I hope you get out there and use these guidelines, share them with your colleagues and your patients, and that if you can, update your lactation policies wherever it is that you work. And I just have the links here that will, you'll have these slides later. We do have a recommended reading list, which is also copied here. And a complete list of references that went into the literature review is also available. Okay, I'm gonna stop share and see if there's any questions.
Thank you so much, Natalie. That was great. If anyone has questions, if you want to go ahead and put those in the Q&A box now. We do have one question in there, but I'll give everyone just a few minutes and then we'll see what we get and then we can start answering them.
Yeah, great. I do see the question from Annalise. What is the impact on prolactin levels with opioids? So you'll see, I feel like there's if you go on LactMed and look at any opioid in that whole list, it always starts with a little blurb about this. I believe prolactin levels are raised, but there's not really evidence on sort of impacts on lactation beyond that, like whether there's actual impacts on supply or anything.
Julia, I see we have a couple hand
Oh.
Hands raised. I don't know
Oh, I can see them. Great. Okay.
if we're able to mute them or not.
Yeah.
I think you might be able to.
I think you might be the only one because you're down as the host.
Let me check here. Yes, so I do have, I can unmute them if they would like to ask their question. I think they had their hands raised in the beginning though, so if you don't have a question, you certainly don't have to ask it. Hold on, let me. All right. Oh, it looks like you are muted if you are trying to ask a question.
Looks like we have, did you unmute or did you give access to Lena?
I did. It shows that she's still muted though. So if you are trying to ask a question. Oh. Oh. Sorry guys, my screen just went. Okay. So we will give access to Autumn had also asked a question. So if you would like to unmute.
Oh, it looks like Lena or Lena is off mute now.
Oh, perfect. It looks like Lena is. And I apologize if I'm not saying your name correctly.
Oh. Looks like Autumn might have taken her hand down.
Hey.
But I did see a comment came in here that somebody had to go and they did say thank you for the presentation. And then, yes, we will be sending out a copy of the slides and the link to the webinar presentation that, sorry, we started a few minutes late, so I missed a little bit of the beginning, but we will be sending out a link to the presentation in about a week or two, depending how quickly we get the link.
All right, we'll give a few more minutes for questions here.
And if some questions happen to come in, Natalie, after the presentation, are you okay with Shalia and myself emailing you? And then we can...
Sure, yeah, that'd be great. And definitely feel free to type in questions also.
And I know we had a lot more signed up for this that it looks like they might not have been able to attend live. So I have a feeling some questions may come in after they've watched the recording. So definitely for those of you who are listening after the fact, please, any questions you have, let us know and we can definitely get those to Natalie. That was a great presentation and a lot of information. My head's kind of swirling.
Thank you. And it is it's a bit of an info blast.
Yeah.
So great. I can have a question for you, Natalie.
Sure.
When you talked about the strips for testing, like alcohol and other substances, like the milk testing strips, where do people get those?
So yeah, so there are tests specifically for alcohol in breast milk, but that's how they're marketed, that are available. If you type in milk test strip in your internet browser, you'll find things, on Amazon or whatever. I am not aware of anything that is marketed for any other substance, and I would love to know if any of those start to exist. I want to know about them.
Definitely.
Yeah, but I've heard some, nothing very solid, but I've heard some things about those strips being maybe not super reliable, and I don't know. And there's not a lot of, when I looked into it, the only sort of research into validating them I could find was with cow's milk, which I don't know if I can really use that there, but plenty of people do use them, it seems like, as kind of a backup, especially if you lose track of time.
Right. Great. Thank you. And I don't see any more questions coming in. But again, thank you so much. Natalie, we really do appreciate that. That was a wonderful presentation. And
Great.
if anyone has any additional questions, you are more than welcome to email us, and we will reach out if you are okay with that.
Yeah. Okay. Well, thank you so much for having me, and have a good rest of your week.
Thank you. Thank you.
Bye.
Wonderful. Let me share my screen here. Back to our. All right. Are you able to see that, Heather?
Yes.
Okay. Wonderful. Let's see. And I can start the video here. All right. So we are going to start the portion on our first steps, updates, and reminders. The first thing that we have up is that we are resuming program monitoring. We did take a break through legislative session. And so we are resuming that. Previously, the last monitoring that we did, we focused just on telephone and telemedicine. This monitoring is going to be a full comprehensive monitoring. So we will request complete client records. And additionally, we will be reviewing records for staff who are community health workers and infant case managers to ensure that they meet the required qualifications. We will be sending out emails and requests for that probably in the next week or two. We are also working on updating the First Steps MSS and ICM provider directory that is online. I have sent out a few emails to coordinators asking if you'll just verify the information that I have. And so expect to see that email coming in the next week or two as well. I'm just going off of the rosters that were sent in and what we currently have online now, just to make sure that everything is accurate and up to date. We also wanted to go over the ICM EPA. And I know that we talked about this last time, just really quickly, the expedited prior authorization code has it has eligibility requirements, so it should only be used when certain requirements are met. And let me pull up hold on, let me pull up Heather, did you say it was Alt-Tab to pull up?
Alt-Tab takes you to whatever you had last opened.
Okay, so we do have the ICM newborn calendar. So you use the EPA if the infant meets all of the ICM eligibility as listed in the guide. If the infant's eligibility for ICM begins during the second month of life, and if ICM services are provided during the infant's second month of life. Let me pull it up really quickly here. Sorry, guys. When you have so many screens open, sometimes it gets a little. There you go. Hopefully, are you able to see that?
Yep.
Perfect. Make this. Now let me minimize that. Okay. All right. So if we're looking at the calendar here, so for example, if an infant was born on March 1st and services were provided on June 2nd, the EPA code is not needed and should not be included on the claim. However, if that same infant receives services in May of 2022, then the EPA is necessary. So in addition, if services were provided in April, then the infant was not eligible, and that will result in a take back of payment. So if we look at this calendar, one of the things to really notice is any of those dates that have a star next to them are the ones that are going to require that expedited prior authorization code. And again, if you have any specific questions about that, please let me know. If you have any dates in mind, you can feel free to reach out, and I'll just make sure that that's that's all good to go.
And the other part of that is if they have that asterisk or the little star next to it, and the services were provided in that first month that they were eligible. So, so for example, the May 1st or 2nd, their eligibility starts July 1st. So any services provided in July, the EPA needs to be on there. But if services are provided in August or later, do not use the EPA. So it's only if it's their birthdays are one of those that has the asterisk, and the services are provided within that first month of their ICM eligibility period.
Thank you for clarifying. All right. And I will turn it over to Heather.
Hey. So I just wanted to make those aware that recently I sent an email to all MSS and ICM coordinators. So if you're a coordinator and you didn't receive an email from me in regards to a survey about the Washington paid family medical leave, please let me know. And then I did ask that each of the coordinators share that with their staff. So the Employment Security Department and DCYF had asked that I send out the survey. They would like as many of the MSS and ICM providers who are providing services directly to clients to take this survey. And what it is they're just kind of trying to get a sense in the state of Washington in regards to paid family medical leave and who knows about it. Are some one-on-ones or some if they're needing to go out and kind of do some more education around that, or if there's others out there who need a little bit more training or education in regards to helping those who may qualify for the services to get signed up for it. The purpose that they want, definitely the MSS and ICM providers, and then also anybody else who is working with not specifically, but especially low income, pregnant, and postpartum people is kind of who they really want to reach out to currently. So if you did not receive the survey from your supervisor, maybe reach out to them and ask them and say, hey, I heard Heather talking about this survey because it is due, I believe, at the end of this week. So because we may kind of, depending on the survey results and things, we might have them as come and speak and do a presentation for one of our first steps webinars. Also wanted to talk a little bit about childbirth education, or CBE. That's another program that I manage and don't talk too much about. So just wanted to let you guys know what's taking place in regards to that program. Shalia has graciously been helping me to update the provider directory because I think what we have online is really old. And so we're working on getting that directory updated. As a reminder, CBE is its own program. So childbirth education services are not allowed in MSS. You need to refer to a childbirth education provider who is been approved by the healthcare authority, because those services are covered for Medicaid clients as well. So directory hopefully will be updated soon. If you are a CBE provider and you're not on the old directory or you haven't been in contact with me, please send me an email and we'll have our first steps email here at the end of the slides. Please reach out to me and let me know, so then that way I can make sure that you are on our list. And then also another thing that's happening with the CBE program is I am currently updating WAC. So with COVID, we had some providers that began providing classes online, and then some were using a pre-recorded online class. And so I'm currently updating WAC so that that can continue now that the public health emergency has ended, where CBE providers can get approval for a class, and then that person, the educator who is credentials and meets the credentials in our billing guide, can then just do a follow-up with the patient or client that took the online class, if it's not a direct face-to-face live online class, but it's one of the recorded classes. So that's a change that we are currently working on, and I believe they call the CR 101 went out. So hopefully that change will be effective January 1st, 2024. And then lastly, just wanted to let you guys know of the Apple Health Unwind. A lot of emails have been going out in regards to the Unwind, and Shalia is going to go to the website that I have listed here. We want to make sure, we as an HCA, that those who have been on Apple Health are aware that beginning April 1st, the agency has gone back to normal, what they call normal operations, which is what operations were prior to COVID. So during the public health emergency from March 2020 and until 31st, 2023, anyone who was on Apple Health, their eligibility was not dropped. They remained on Apple Health, Medicaid, no matter if their income increased or whatnot. The only time that somebody was taken off was if they requested it, they moved out of state, or they passed away. So beginning April 1st, the Healthcare Authority is now starting renewals. It's going to take about a year. They're sending out mailings to a certain number of people every month. And so one thing that I want to stress highly is to make sure that you have any of your MSS and ICM clients and parents go into their eligibility through Health Plan Finder or whatever system that they have that they signed up for Apple Health, and make sure that their information, contact information especially, is up to date. When I do the monthly MSS client list, I'm noticing things are a bit different. The mailing addresses are being updated more often, but previously, and there are still some where the residential address where the person is residing has been updated, but their mailing address hasn't been updated. So a lot of times it's still the mailing address was something that was from 10 years ago. So make sure that when you're talking with somebody that you let them know that they need to go in and update their contact information and really specify that they should look at what's listed as the mailing address, because we want to make sure that when it is their renewal time, that they get the mailing to renew, and then that they do go in and renew. So there is some information on this website that Shalia has pulled up. If you scroll down a little, it talks about kind of what's taken place, and then how now we're going back and doing the renewals. So, oh, the other thing too is with this, this renewal is happening in all the states, and that's bringing out the scammers. So please also let your clients know that the Healthcare Authority, Medicaid, will not ask for any money over the phone or via text. The only time that we will ask for money, and it's not really asking, but that's the other thing. Another change too is of July 1st, the CHIP, Children's Health Insurance Program, those premiums have begun and started up again. So those invoices or premium payments requests will go out, and that's the only time that anything would be asked. So please let people know that we will not be asking for any of their confidential information like social security numbers or anything as well, and that we won't be asking for money or gift cards. I think a lot of times that's what the scammers like to use is gift cards. So that's another message to make sure that you share with your clients. So on this website, that's a lot of information. It kind of has right there where April 1st, where the Healthcare Authority has gone back to kind of how it was pre-COVID. There's some frequently asked questions that can be helpful if you have some questions coming from the clients. If you are not signed up for Gov delivery messages, definitely you can make sure, I think at the bottom of this, to sign up for those. And a lot of the messaging that's on this website goes right there. If you click on that envelope, it'll take you to where you can sign up if you're not already signed up. If you are signed up and only receiving the First Steps MSS and ICM messages, you can also go in and sign up for other topics, and eligibility or client information, I believe, is another one that's there. Go back. If you scroll up just down just right below the video, I think it is. Yes. So we also have, the Healthcare Authority also has an ambassador program for anyone who is interested in volunteering to help people to renew and get trained in how to use the system. So there's the ambassador program as well, where they do provide some training on what to do. And then also there are translated resources available, and it's in 15 different languages. If you have someone who needs to report a change and they do not speak English or one of the 15 languages on there, they can always call the call center, which I believe the number, you can scroll down just a smidge more. Actually, it might be on that language fact sheet, but you can always call, and the client who's calling can say which language that they speak, and then the person on the other end can put them on hold to get an interpreter. So it's not just these 15 languages. We do have many more. When I used to work in the call center, a lot of times I would answer and then I would just hear the name of a language, and so I'd be like, okay, hold on, and I would put them on hold and get that interpreter. So there are many other languages that we can get to help to communicate with that client who's needing to report a change or just needs some additional assistance. I think, scroll down a little bit, I just want to make sure. I think I touched everything on that site. Yes. So just the big things are, beginning April 1st, mailings have started going out. July 1st, the Children's Health Insurance Program, those premium payments are beginning again. We do also have the APC after pregnancy coverage. And so again, coverage is continued 12 months after the pregnancy has ended. So as soon as the pregnancy ends, that's another thing, is to have your clients go in and make sure that they update that estimated due date in the system. So then that way there's no break in coverage from that 12 months with the APC program or APC. So they continue receiving their coverage, and there's nothing in the system that accidentally drops them because we didn't know the end of the pregnancy. Anything else you can think of, Shalia? Any questions come through?
Let me check. I don't see any questions. So if you guys have any questions about any of the updates or reminders, again, you can type them in the Q&A box, or you're always welcome to email us afterward. Either way works. While we're waiting to see if there are any questions, this is our quarterly webinar schedule, our anticipated quarterly webinar schedule. So I do have the next one scheduled for October 19th. I have not sent out the Gov delivery yet. It usually goes out about four to 5 weeks prior to that date. So be looking for that. Again, if you are not signed up for Gov delivery, please do so. That's where we send out the signups and the information about the webinars. And I do see that we have, yes. And you put the website in the chat that you were just referring to. The APC website or the one that I just had up? Or the renewal website? I can put both in there. If you give me just a few minutes, I can put both in there. And then I think we have a hand raised as well, or we did. Did we have a hand raised? Okay, let me, oh, yes. It looks like Robin has her hand raised, so I'm gonna unmute you if you have a question. Okay, there we go.
Hello, this is Robin. And with the medical renewals, I have found that many of them are randomly getting, not getting the information, they're not responding, which is their responsibility, but it's happening before the baby delivers or right after the baby delivers. And obviously we can just get them reactivated, but I didn't know if that's because it's kind of random sending out and renewing, if that's going to be an ongoing issue.
So I am going to make a huge assumption that that there's no estimated due date or EDD listed in the system, because it shouldn't be dropping somebody if there's an EDD in there. So if
Okay.
somebody's not on, if they're on just a general Magi type program and not on pregnancy medical, and they didn't list their EDD, then that's probably why that's taking place. I believe from some of the information that I read is that they're doing the renewals based on when that person's renewal would have been. So say April of 2020, 2021, whenever, that's who it'd be the group for April. And then the next month's going to be who would be for May. And so that's going to be my huge assumption, is that we probably don't have an EDD in the system. So that's another thing when you're working with clients who may have been on Medicaid for a while, make sure that they go in and they put that in the system. So that way we know that, even if they haven't delivered yet, so that way it's not going to stop them. And I think the system should at least do then that their renewal would be 12 months from whatever that EDD is in the system.
Okay, that's good to know. And most all of mine do it via phone, and I am concerned about the amount of navigators or people helping them. And I heard you guys say we can learn to assist. If we could just make sure that link's sent out, because I'm concerned the phone ones are going to get over inundated, because most of my moms don't know how to log in.
Yeah. So Shirley, if
So.
you go up one slide, that one. Oh, no. Yeah. So the nice thing is that the website's really easy. It's short for that information that has a lot of the renewals and the ambassador program and some of the other things. So hca.wa.gov/PHE for public health emergency. That's the website that I have found has a lot of information and then has links to get to other information. So I found that website's kind of the most helpful to have most everything that you're going to need.
Okay, thank you.
I do see a question in here about any updates on MSS and ICM requiring in-person appointments. The telehealth, telemedicine visits, it's going to continue. I don't see an end date for that. In regards to in-person appointments, I don't know if you're meaning like possibly in the future, we may require that the first visit be in person, because I believe that the way that the bill was written by the legislators does require that if somebody's not an established patient, that at least the first visit has to be in person. But that keeps getting extended out, so I don't have any updates on that. But definitely right now, telephone and telemedicine visits are allowed, and that's even allowed as the very first visit if needed. So again, any questions? This is the email that goes to both Shirley and myself, or we have access to it, I should say. It doesn't come to us, but we have access to that email. So any questions, you can always reach out to us through that email address.
And I did put in the chat box the link to the renewal webpage that we were just looking at, as well as the link to the ambassador page as well. And I will make a note to send out those links as well when we send out the webinar materials also.
So if no more questions, we can give you guys back some time in your day. Getting close to lunchtime. So again, any questions, just reach out to Shirley and myself, and we will be able to get you an answer quickly. Sometimes we do have to do a little bit of research depending on the type of questions, but definitely reach out to us, and we're here to help in any way that we can.
Thank you so much, everyone.